Can you guys
I'll
call me?
have my own table.
I can hear you. Everybody hear me?
Yes.
Alright. So other cardiac conditions we're gonna talk about before we get done, hypertension, cardiac arrhythmias, pulmonary hypertension, and cardiomyopathy. What is hypertension? Same thing as it is an adult, elevated blood pressure. Right? It's not very common in children, however, due to our obesity crisis, we are seeing the incidence rise. However, it is often associated with other issues as well. If they have other cardiac issues, if they have other disease processes, then they can have elevated blood pressure as well. So if you look on page 1002, it gives you delineated, defined set parameters for what elevated blood pressure is in each age range. Okay? Page 1002. Very top. It talks about for each age range, what to look at and what to look for. Signs and symptoms in these children is typically going to be, they'll be irritable. If they're little, they don't really know what's going on. And they may do some head rubbing or head pounding in your younger kids, oh, my head hurts, it won't stop, right? They cry, they're irritable. As they get older, they may have some changes in their vision, some dizziness, and headaches. Headaches are going to be across the board in all of them. That we'll see some, changes in them. A lot of times, because, again, blood pressure is one of those things that silently rises and your body gets more and more tolerant of it. That can happen in children too. If there's a cardiac condition that's causing that hypertension, then it may be something that comes on all of a sudden. But typically, blood pressure, right, is a very general, slow process in rising. They're still going to have some of that dizziness, headache, those types of things that we need to be watching for, as well as checking their blood pressure. So they do say that we really want to check the blood pressure in children that are older than 3 years old at their annual visit, just to be looking for that. Some of your kids do have white coat syndrome, where the blood pressure gets elevated at the doctor's office. So we'll want to have the parents, if we're finding an elevated blood pressure, we're going to want to have the parents buy a low blood pressure cuff and check their blood pressure at home and see if it's more regular or what it's doing at home. Just like with adults, we're going to have them do a blood pressure reading at different times of the day and check their blood pressure and then make our diagnosis off of that, okay? We're gonna look at familial history. My brother has elevated blood pressure. When he was 10 years old, 10, 12 years old, he went for his first physical to play basketball. Right in Oklahoma plays basketball. And so he went for his physical, and his blood pressure was so high, they started him on blood pressure medicine when he was like 12. The doctor told my mother that he could literally be scared to death because his blood pressure was so high. And that was just at the doctor's office. And so some kids, now, I will tell you that my brother was adopted, and his mother was an alcoholic and a drug addict. So my brother had some history of being a drug baby, alcohol baby, whatever. Don't really know. I just know she was a drug addict and a drunk. And so that has played a role in his health as he has grown up. So recognize that those babies that are moms, and a lot of times that's why it says familial history, medical history, what were they like when they were born, and what was their condition, what was their mother's prenatal history. If we're seeing blood pressure issues, it could be related to some of that, okay? So that's another one of those things that we look at. Prevention is our, with blood pressure, what can we do to prevent high blood pressure? Some of it's genetic, but what isn't genetic?
healthy diet and exercise.
Good. Diet, exercise, all of those things, keeping, just like adults, keeping them within their healthy BMI. Not feeding them fried foods all the time, lower saturated fat diets, all of that increases. Caffeinated beverages. Watch your kids that drink a lot of pop, that has a lot of caffeine in it. Your, what are those caffeinated drinks? Your energy drinks. And I will tell you that kids that have cardiac issues should not be drinking those, okay? You should not, your kids, or if you have a history of any cardiac history at all, you should not be drinking energy drinks. That caffeine can really cause high blood pressure and overstimulate your heart and can cause you to go into heart failure, okay? I can't tell you that enough. And educate your parents on that, okay? Your teenagers, educate your teenagers. Your driving teenagers that can go out and say, I need something, I'm tired. And they drink that, and the next thing you know, they're in heart failure because their heart has worked so hard to overcome that energy drink. Okay, I'll get off my box. Cardiac dysrhythmias. Going back real quick on your blood pressure medication, and if you look, there is a table on page 1004. There's information on ACE inhibitors and ARBs, ACE and ARBs there, and quality patient outcomes. All of these boxes that you see, nursing care management, it's all right there, guys, so take a look at that. And then if you turn the page on 1006, it talks about the medication for antihypertensives. So page 1006 gives you your antihypertensive drugs commonly used in the treatment of pediatric hypertension. Page 1006. We're not going to talk about lipid studies in children, and that is really rare unless they have a congenital defect that elevates that or causes some issues, but it's really rather rare. And we do see it with incidences rising with your pediatric obesity, but recognize that that's it's rare, and it would have to be a genetic predisposition for that to affect children. That's really the main thing. Medications are going to be pretty much the same as what you give adults, just in lower dose. All right. Next, we're going to talk about cardiac dysrhythmia. Start on page 1009. The very bottom. So basically, with cardiac dysrhythmia, there's an alteration in the normal electrical flow within the heart. So it doesn't go where it needs to go. This alteration will often affect cardiac output. If your heart's not beating like it's supposed to, recognize that the way the heart beats, the atrium and then the ventricles, and how it does its pumping and its pulling, it's all related to that electrical conductivity. It sparks it, and it makes it grab, and then it sparks another, and makes it grab, and it lets go. And that's always going on in your heart. Whether you're thinking about it or you're not, your heart constantly has this electrical conductivity that's running through it. So when we don't have that like it's supposed to, our cardiac output will be affected. If it's the top part of the heart, if it's the bottom part of the heart, it doesn't really matter. If part of it isn't working right, you're not going to be able to pump effectively and efficiently to get the blood out of the heart or pull it into the heart. So you're going to have issues. They'll have palpitations. There'll be shortness of breath. It can lead to congestive heart failure. There may be syncope, which is what? Tap out, right? Dizziness. So basically, we do an EKG. They may wear a Holter monitor for a couple weeks if we can't pinpoint exactly through a 1-minute EKG. Right? When we do an EKG, we hook them around to all these leads and they lay real still for about a minute. It doesn't take long. There's no prep for it. Right? They just put all these little stickers on and tell them to lay real still for just 30 seconds, a minute, it's nothing, and it's over. and then we pull the stickers off of them in their bed. But what we'll see, perhaps in that, is some bradycardia, makes us too slow, tachycardia, makes us too fast, or heart blocks. Heart blocks means there's something within that electrical conductivity that's messed up. So there's some tissue in there that's messed up, that's causing that heart block. It's not allowing that electrical impulse to go from one part to the next, and so it shows up as heart block. What that means is your EKG will be off. There's different levels of heart block, so they look a little bit different. It progresses from an extra P wave here and there to all the way to they're divorced, and the P wave and the QRS aren't combined at all, and you never know where you're going to see one or the other. But it'll show heart block. The nursing care is going to be prevention. So again, if we know there's an issue with their heart, or if they've been sick, anything that can lead to those cardiac dysrhythmias. Remember, we talked about emetic fever. We talked about Kawasaki disease. All of those things that can cause scar tissue within the heart can cause cardiac dysrhythmias. So prevention of those. Prophylactic antibiotics. Antibiotics when we get strep. Treatment of Kawasaki disease in a timely fashion. Those types of things. That's your prevention. And then medications. We're going to give the digoxin. We're going to give, maybe if they have tachycardia, we might be looking at a calcium channel blocker or something, or a beta blocker that lowers that heart rate if they have the tachycardia. We may even progress to some ablation if medications are not effective. Okay, where they go in and they actually put scar tissue in the heart to keep it from continuing to trigger. If you have atrial fibrillation and your heart is sitting there jiggling and jiggling and jiggling and your ventricles don't know what to do, right? Sometimes we get rapid ventricular response, which means the heart, the bottom part of the heart starts reacting to this jiggle, and it says, oh, I need to squeeze out time. So that can lead to ventricular tachycardia, which can lead to death, right? So sometimes if we have atrial fibrillation, we have to go in and ablate or burn that area to stop the ventricles from picking up on that atrial fibrillation impulse, right? To keep them from going into ventricular tachycardia. So sometimes it does lead to ablation when they have tachycardia. And with bradycardia, a lot of times they'll put in pacemakers. So think about your pacemaker education, that type of thing. You're going to teach signs and symptoms post-operatively, right? Infection, what it looks like, how to take care of it, that kind of thing. Pulmonary hypertension. This is when the blood pressure is elevated in the lungs. A lot of times it results from cardiac defect, or it can be caused by disease. It is severe, and if not treated, it does result in death. Pulmonary hypertension can result in death. The diagnosis on this may not be seen for months. It typically starts with some heart failure, but once it progresses, they'll have a murmur. They'll have enlarged neck veins. Their liver and their spleen will be enlarged. They'll have, let's just say, leg swelling, not leg swelling. Leg swelling and clipping of their fingers. We're going to check and do some tests to check out the pulmonary blood flow, which is the pulmonary arteriogram, echocardiogram, chest x-ray, heart cath, and pulmonary function test. Nursing care will include a lifetime of medications and treatment and education, and you'll need support for this family because pulmonary hypertension ultimately leads to death. Okay? When it doesn't matter if you're an adult or a child, when you reach the point of pulmonary hypertension, you have some progression in your disease process that has caused your lungs to be constantly full of blood and increase the blood flow to your lungs more than just normal heart failure. It's past that point. Pulmonary hypertension retention is basically saying, ultimately, you're gonna die from this. We're gonna give you medications to lower your blood pressure, to increase your pulmonary function. We're going to do everything we can to, treat this, but the reality is, in time, it could possibly kill you. When it reaches the point of right-sided heart failure with systemic venous congestion, they have the edema, that's when the prognosis gets really poor, okay? So we've got swelling in the heart, in the lungs, and then it backs up, ultimately backs up and starts backing up in the body. That's when we start to see a poor prognosis, okay? Again, your pharmacological therapy is there on page 1013 at the top. There are some different medications there that it talks about, and it gives you some pretty important information on those medications. But the main thing to remember is we want to keep them on the medications. It's a lifetime thing. It's not something they can go off of, and they have to continue to manage that. And they may need oxygen as well, so we have to teach about oxygen therapy and all of those things. Education and discharge instructions, again, look at your nursing care management on page 1013. Talk about teaching oxygen. Don't smoke around it. Keep it on all the time. There are so many new devices out now where they can get the little oxygen, portable oxygen, it actually like takes oxygen out of the air and concentrators that they can carry around with them and constantly have oxygen available to them. So there are things, and not have to carry the tanks and pull the tanks around like they used to. There are neat little devices out there now that are really portable and quite handy for children and adults. Okay, so cardiomyopathy, this starts on the bottom of page 1013. Oh, sliding off this chair. Sorry for all the noise. It's basically any type of abnormality in the myocardium, which is the muscle of the heart, myomuscle. Okay, so cardiomyopathy is the cardiac muscle gets dilated. Hypertrophy means it gets thick, and it's got extra muscle tissue in it. It's built up muscle tissue. It's stiff or it's inflamed. There are a lot of different classifications and causes. Basically, what you need to know is the cardiac muscle no longer functions adequately, right? Again, they have to seek treatment to sustain life because when it gets to that point, they can have issues. The symptoms are going to be really vague. They're going to have weakness, excessive tiredness, shortness of breath, poor feeding, lightheadedness. We're going to look at their physical history. We're going to look at their family history. We're going to listen for murmurs or gallops. Venous congestion. What does venous congestion mean, Enid? Tell me what venous congestion means. Enid?
When the blood pools, like in the lower extremities, like it doesn't make it back up to the heart.
Okay, good. So veins, venous, the veins get congested, everything gets cooled, that kind of thing. Very good. We're going to look at their EKG or ECG, and we're also going to look at the echocardiogram, which shows exactly where the heart is malfunctioning and where it's not pumping effectively and what's going on. The main thing we can do is prevent it, okay? We want to treat the underlying cause. We want to find out what's causing the cardiomyopathy and treat it. We're also going to treat the symptoms. So if we've got venous congestion, we might be giving some Lasix. We might be giving We're gonna make sure that we're giving them something to help the contractility of their heart, so probably some digoxin, those types of things. ACE inhibitors, angiotensin, ARBs, beta blockers. We're also, because they have poor feeding, we may be doing some nutritional supplementation. And then there's your Lasix and your ionotropate. That's your digoxin. We want to support these people and their families and these kids. We're going to give them resources, education, and discharge instructions. The other thing I want to mention that I think I did not mention is Kawasaki disease. Those babies are kids are extremely irritable. And they're just going to cry. And rheumatic fever is going to be the same way. They hurt all over. And they're just going to cry. And there's not a whole lot that we can do about that. You know, we can give them some medication, pain medication, anti-inflammatories, those types of things. But the reality is, it's just uncomfortable. And if a parent comes to you saying, oh, my kid's crying and it won't stop, part of the disease process. And just continue to hold your child. Give them comfort items from home. Soothe them to the best of your ability, but recognize that part of that's just how they're going to be. Because it's so uncomfortable, okay? I forgot to mention that earlier. All right, so now we're moving into pain. Pain, we have to go back to the other chapter 5. Chapter 5. We talked a lot about pain when I talked about growth and development, and I talk more about pain now. The reason we're putting it here is recognize that these kids with open heart surgery are going to have pain. Your kids with rheumatic fever and Kawasaki disease, they have a lot of pain. So we want to address pain. This will be the primary lecture on pain from here on out. So everything that's in this portion of the lecture is going to be what you need to know for pain from here on out with the rest of your lecture. Okay. So pain control should be provided for whether it's a minor procedure for newborn or for children. We give the little boys that are getting circumcised a nipple or a pacifier with sucrose on it. That is a pain reliever for an infant. Sucrose causes endorphins to be released in the brain, which is in a newborn. It's like a pain medication. It makes them feel good, very soothing. Unfortunately, when we start doing that as infants, then that carries throughout the rest of our life, and then they look like me when they're old because they like to eat to get soothed. I'm sorry, that's just me. Cookies are my friend. Not really, but they go straight to my head. But anyway, we want to know that some of these procedures, as they get a little older, anticipation and sometimes even cause more anxiety, which then inflicts more pain. So we want to make sure that we're only telling them what they need to know. We don't want to make it sound worse than it is. We want to make sure that we're speaking on their level of their developmental age. Recognize that developmental mental age is different than physical age. Okay, so be looking for some of that in your stems of your question. If the child is uncooperative, they may be in severe pain, or they may have had painful procedures before that they didn't get good coverage on. So that increases their anxiety and makes them more uncooperative to help to be there for you. So there's physiological pain, that's actual body pain, physiological disease-caused issues with, actual breaking of a bone, issues with stress settling in the joints, those types of things, physiological pain. Then there's behavioral pain. This is a mental aspect of the pain that adds to it. Are they anxious? Are they stressed? Those types of things that add to that physiological pain. And depending on what's actually causing their pain is how we treat it, right? If it's a mental or behavioral pain, something along that line, then we're going to educate, we're going to soothe, we're going to do what we can to help them overcome that behavioral pain. Whereas if it's a physiological pain, we're going to treat it with pain medication or something that helps to remove that physical pain, versus the behavioral pain may also be something that they're doing that's causing or increasing their pain. Okay? So recognize that those are different. All right, sorry, there was some stuff on chat, and I was just checking that. Your lab and diagnostic book is the best resource for your lab values that you need to know for this exam. Just so you know. And that was on chat, so. All right, so different tools are used. Again, physiological pain, clinical manifestations. What do we see in a kid that's causing, that has pain caused by physiological needs? Tachycardia, arrhythmia, and they may have inadequate lung expansion depending on where their pain is. They may not be able to cough. They may have some hypertension because of the pain. They'll have some pupil dilation. They may be pale. They may have some sweating or diaphoresis or diaphoretic, increased perspiration. And they'll have a secretion of catecholamines, adrenocorticoid hormone. But fight or flight, so much again. Actually, it's fight, flight, or freeze, right? Fight, flight, or freeze. And we'll see some of that because they're in pain and they're uncomfortable. With behavioral pain, we're going to see that short attention span, that irritability, facial grimacing, biting or pursing lips, protecting that, so they're going to protect, they're going to withdraw, they're going to do what they can to protect painful areas. They may drop their knees. They may be lethargic, withdrawn, and it's going to upset their sleep because they're in pain. They're not going to be able to sleep well. So sleep disturbances. So we want to make sure that we're using the appropriate tool for the age of the child. Recognize that a lot of these tools are only estimates of, and they're not a real good actual, this is how the child's pain is, because we're looking at their behaviors. We're looking, or they're pointing at a smiley face or whatever, or a frown or crying or whatever. We're looking at those things, but we don't know because pain is subjective. Pain is what that person says it is. And when you have a child that can't communicate with you what that pain is, then you can't have a true gauge. It's an estimate, right? And some of it only relies on observation, like we talked about, where you're looking, are they grimacing, are they crying, are they consolable, are they not consolable? And the NIPS, when we're looking at those different pain management, excuse me, allergies, not corona. And when we're looking at some of those different assessment, pain assessment tools, and it's going to be just looking and seeing, observing what they're doing. And some of the different names of tools are the NIPS, the Comfort B, FACES, FLAC, numerical, and word graphic. Some of those you've probably heard and are fairly familiar with. And table 5.5 gives you different rating scales and talks about some of those different rating scales. Your NIPS is going to be on page 144. And then the table 5.5 is on page 146. And that one talks about your faces and your word graphic and the numerical one as well, okay? So we look at those tools to help us to figure out where the pain's at and how bad it is. Toddlers can usually grasp the concept of more or less, and you only want to give them a very few choices. That's where your faces come in. This is where do you have some, do you have just a little bit, or do you have a lot? those are, you wanna keep your choices down to a minimum because they're not old enough and they don't have the capacity to make a decision, like on a scale of 1 to 10, they don't know, right? The toddlers don't know. In order for the numerical scale to be used, the child has to understand rank and order. They need to be able to grasp that concept of 0 is less than 10, 10 is worse than 5. They need to be able to rank and understand that. And sometimes that doesn't come until they're older, 6, 7, 8, depends on the child, and you have to ask the perfect questions to know whether you can use that numerical playing scale or not, okay? Usually, you can also use blocks. This is a little bit of pain, this is a lot of pain, you know, and use a block. When you've got 1 block, 2 blocks, 3 blocks, this is my pain. Where's your pain? If they can understand some of that as well, that's where it talks about the blocks. By the age of 8, usually they can give you exact location, what it feels like. Is it like somebody stabbing you? Is it, you know, they can give you a little bit more description. Is it dull? Does it ache? Does it, you know, what does it look like? Is it burning? They're usually able to do that by the time they're 8 years old and older. So our first intervention is going to be acetaminophen, NSAIDs. We start with those first, just like we do with adults, guys. Everything starts with your lowest. So actually, what do we start with initially? We're going to start with soothing, right? Things from home, non-pharmacological interventions, rub their back, positioning, those types of things first. Then we proceed to pain medicine. We proceed to Tylenol first. Then maybe, depending on the type of pain, we might choose an NSAID over Tylenol, depending on what's causing their pain, right? Is it swelling that's causing their pain? Is it fever that's causing their pain? What's causing their pain? And that's going to help us determine what we give. We're going to use distraction and relaxation techniques. Some children respond really well to hypnosis. We may also use topical anesthetics. So there are NSAIDs as well as lidocaine and topicals that really help. So if we know they're going for a procedure, we may use a topical gel, a lidocaine gel. A lot of times we want accessing ports in children. We have them put lidocaine gel on 30 minutes before we access the port to reduce that because it's very painful. It's a painful procedure to access a port. So we may do that. And sometimes even an hour or 2, depending on what we're using. But one of the new ones that's come out that is over the counter for an anti-inflammatory is Voltaren. You've probably seen commercials for that. And it is a topical NSAID. So sometimes we might use that. So recognize that there are different ones. And then once we try all of those and that's not working, then we might move to opioids if we need to. Again, we want to go with the less invasive, the less potential for addiction, potential for changes in mentation, those types of things. So we start with the less and go to opioids. So it's really important that we teach our parents how to judge pain, how to treat pain, and child, if they're old enough. Some children are old enough to dose themselves for pain. If it's a sickle cell kid, has pain a lot, and they recognize when they have issues with pain, they need to know when they need to take anti-inflammatory or what they need to take. And so sometimes if they're old enough, we can teach the child. We want to make sure that they're taking pain medication before the pain gets out of control. And that's that case for everybody. We want to make sure that we're addressing any factors that aggravate it or make it worse. So if they're having issues, or they're doing something that causes them to have pain, we may pre-medicate. Just like adults, guys, if you're going to get a child up after surgery, you want to give them some pain medicine before you get them up and get them moving, right? Because that's going to increase their discomfort, increase their pain. And we always want to start with the non-medication intervention first, right? Just like I said. So, this is an illustration of some different things that they're doing for this child. And it talks about the different interventions for this child that has an issue with cardiac problem. So they do a cerebral saturation monitor, which monitors their blood flow to the brain. They have them on a ventilator. So the ventilator pumps blood directly into the lungs. They have the EKG monitor, so you see all your different EKG leads here. There's 3 of them, which monitors the heartbeat. They have an IV catheter here, down here. There's one here too, looks like. But the IV catheter, they've got it down here that delivers medications, and it also, because that's going into an art line right there, it's monitoring his blood pressure as well. And there are pacemaker wires here. They have a chest tube here. They have an O2 sat monitor. Monitors oxygen in the blood. It's going to the baby's bowels, liver, and kidneys. So that's actually inserted. And then there are drain tubes as well to pull out, right there. That pulls out the excess fluid from the lining of their abdomen, the ascites. I don't know how many of you have been to PICU yet, but you will see this type of thing at PICU. Not so much NICU, because NICU is neonates, and if they have to have heart surgery, they just send them to PICU before. And so PICU is the one that handles the post-cardiac babies and things like that. One of the first times we went there, I had a student, and she came to me and she said, I don't know if I can handle this. That baby has 9 different IVs and was on a ventilator, and yes, just the way it is, and it is scary. So a case study real quick. We got done. And I do want to end with this screen before they shut us off. They're not gonna shut us off today though, because we're supposed to have a study session. Ina, do you wanna go get Miss Chester? So we can do study session? Thank you. And go back to this one. Hunter is 1 month old today. At birth, Hunter was diagnosed with a VFD and recently started developing signs of respiratory distress and difficulty with feeding. Hunter's mother had been taught to watch for these signs as possible indication of CHF. Hunter was quickly hospitalized, so his CHF could be treated with digoxin, furosemide, and potassium. Over the next 2 days, he lost weight and gained due to fluid retention. Corrective surgery was performed to place a patch over the septal opening. Hunter was cared for in the NICU, or PICU, after surgery. So, come to all. Why did Hunter develop CHF? What caused that CHF? Okay, so explain that. Okay, so the septal defect was part of the cause. So explain that to me. What do you mean by that?
Blood flow wasn't going to the right places whenever the heart would pump.
So the heart would pump, and it would push it over into the right side, right? It would then develop and push it into more blood flow to the lungs, which then caused heart failure and pulmonary issues. So Enid, why was corrective surgery performed so soon?
It was starting to cause respiratory distress.
Good. It was causing respiratory distress. We were seeing issues with that. So Stillwater, is Hunter at risk to develop CHF after surgery?
Yes.
Yes. Good. Why? cancer. Why? Why do you think he's at risk after surgery?
He already has that history of it.
He has a history of it, okay? So there could be some issues with the repair, right? And so it can cause issues within his heart because it's used to having that hole there, and so that can cause some issues, yes. We can also have issues where the repair doesn't work, right? Or elevated blood pressure can cause the repair to not function as it should, any of those things. And because anytime we have cardiac surgery, we have an increased risk for heart failure, okay? Just changes the makeup of the heart, it changes the heart itself and the way it pumps and how it works. So what teachings do Hunter's parents need to care for him at home?
They wanna weigh him daily.
Okay, I need one person at a time.
Okay, cool. Don't pick him up by the arms.
Okay, if you had open heart surgery, you wanna be careful of that. Most likely with this one, it's done through a heart cath. Typically VSD repair is done through a heart cath. But if for some reason he had a pericardial window or a open heart surgery, then yes, for sure. What else?
Watch for signs of infection.
Yes, how to watch for infection, good,
Stay on top of medication regimen.
awesome.
You wanna do daily weights.
Yes, keep an eye on daily weight check. What did you say? Yes, teach them the signs and symptoms of CHF returning, which would be irritability, poor feeding, all those things we saw in that first. Good job, guys. Okay, so, any questions? I like to end with this picture, okay? Trust yourself, go with your gut, you know more than you think you do. You can do this. You can do it. Okay, all right, Miss Chester,
Yes, ma'am.
are you ready?
Can you hear me?